The Kaiser Family Foundation presents health08.org, election news, analysis, and events.
Dr. Epperly, thank you for joining me here today.
Thank you.
You represent family physicians.
I do.
What, in their view, is the single most pressing problem in terms of health care?
The biggest issue right now facing the nation is access to health care. And what the American Academy of Family Physicians wants to do to help with that is create a system of patient-centered medical homes that will allow all patients in America a place to be seen for preventive, acute, and chronic care.
And the patient-centered home is something that the association has been talking about, I think, for several decades now, right?
Yes.
Why is that the basis, the core of your proposal?
Yes. We recognize that there is both quality and lower cost if patients have a relationship with an established personal physician. In that relationship is trust and knowledge. So if each patient were to have one place to go with his or her physician and his or her expanded medical team, then all of those care items can be provided in one place so that it's the right place at the right time, the right type of physician, the right type of care. And in that comes healthcare quality and decreased cost.
And so the family practitioner, in a sense, becomes the gatekeeper, which kind of became a dirty word back in the 90s with HMOs. So what is the difference?
Yeah, we prefer to see it as a gateway instead of a gatekeeper. The whole gatekeeper concept was like building a barrier, building a wall so you couldn't get out to see other physicians. What we recognize as the value as a gateway is that it's a focal point where people can come for care, and then if the patient needs additional care, the physician can help educate the patient and get them onto that next level of care. So we don't see it as a wall, i.e. a gatekeeper approach, as much right now as a gateway. One that facilitates care, one that connects the dots for the patient, one that gets the patient then into the system in an appropriate way.
I have one very practical question. It seems to me that general practitioners, family practitioners, don't have enough time in the day now. How would they, in your proposal, where it would take so much more time and so much more caring and information, where would they find the time?
Yeah, excellent question. We are caught on a hamster treadmill right now of face-to-face visits. The whole concept is to expand the medical team so that we can use nurses, medical assistants, social workers, other members of the team to do much for the patient, between patient education, helping them understand certain things so that the physician's time can be leveraged for the most important items in terms of the critical thinking or the diagnosis, the management, the prescription of medications. So in an expanded team format, we see that we can get more care done for the patient. Now, what must come with that then is payment that would be for non-face-to-face visit time. Because to integrate and coordinate that care will need to be another payment mechanism. We call it the care management fee that would be so many dollars per patient per month that would come in to allow the practice, to allow the patient-centered medical home to provide that non-face-to-face visit time to make sure that our focus on our patients is to keep them healthy as opposed to just react to their sick care, to react to their illness.
How does that idea fit into the larger picture of healthcare reform? Is what you just described, can it work in a private-public system? Must it only be public?
Yes, we see it as a shared responsibility that can happen between insurance companies, the federal government, state Medicaid programs, health insurers, employers. We believe that actually there's synergy in bringing this all together in one complex way that helps focus on this patient-centered medical home and getting patients back to that location for the majority of their care. What countries have found outside of the United States is that when the system is foundational on the medical home and primary care, that it actually saves cost, improves quality, and the healthcare outcomes of the patients are improved. And what America is recognizing now is that if we get back to that type of care system, instead of the fragmented, chaotic, specialty-oriented care, that not only will we save cost and improve access, but we'll actually have a healthier country.
But does the Academy have a preference for single payer, for public, for private, to make this happen?
No preference for single payer. What we recognize is that we want health care for all. And how that all comes together is certainly up to the country to decide. What we're focused on is the concept in general. How it's funded can be left to others to try to sort that out. We recognize, though, that the strength of America's healthcare system will not lie in any one area totally. We see more of a synergistic approach by bringing multiple groups together.
What role, then, would the federal government have in making this idea of the academies real?
Yes. Couple things. Right now, Medicare has in its newest legislation and its 2004 Medicare legislation pilot programs for patient-centered medical homes. Mm-hmm. So proof of concept.
North Carolina? Is that right?
Well, North Carolina was a Medicaid project.
Okay.
But Medicare itself will also be piloting these programs. I'm glad, though, that you mentioned North Carolina, because the Community Care of North Carolina, CCNC project, did show that a patient-centered medical home saved that state $200 million in its first year and $250 million in its second year of implementation. Again, by integrating and coordinating care, it kept people unnecessarily out of the emergency room, saved hospitalizations, and actually the return on investment was the decreased utilization of ERs and hospitals, which is what the savings were.